In this video, I now present to you 9 different scenarios of an opening in the posterior capsule during the phacoemulsification of a patient with a posterior polar cataract. Let's endeavor to try and get a deeper understanding into how it happens, as well as what are the management strategies that would work best for the patient in managing such a complication should it arise. Let's look at the first case. In this case, you will see how the surgeon is aspirating the epinucleus in the epinuclear mode of phacoemulsification. Under the epinucleus that's being emulsified, you will notice the dense condensation of the cortex, which is typically seen in a patient with a posterior polar cataract. Just to enhance your understanding, this is not an opening in the posterior capsule. This is an intact posterior capsule with a mere condensation of the cortex in a circular fashion, which is very typical in a patient with a posterior polar cataract. In the following video, I'm going to now demonstrate to you what a typical opening in a polar cataract would appear like intraoperatively should it occur. I think you will be able to appreciate a posteriorward bowing of the cortex, which signifies the splaying open of the posterior capsule due to the irrigation of the phaco in this case. This appearance of a posteriorward flapping of the cortex and splaying open of the posterior capsule is indicative of an opening in the posterior capsule, as opposed to the previous case where it was a fixed round circular opening signifying only a condensation of a cortex in the previous case. Let's now move to the third case. Now, in this following patient with a posterior polar cataract, the phacoemulsification part of it, that is the nucleus management, was uneventful. Let's see what happens during irrigation aspiration. It's not that uncommon in a patient with a posterior polar cataract, wherein, whilst performing an irrigation aspiration, you start to see that as the cortex is getting aspirated, there is the typical spindle-shaped opening that goes from equator to equator in these cases. Now, what signifies in these patients that the vitreous is undisturbed is the fact that the shape of this opening in the posterior capsule remains undisturbed. That is, the opening in the posterior capsule remains constant in shape. There is no widening of the opening in the posterior capsule, which would otherwise signify a vitreous disturbance. Now, should this be the case, you only need to ensure that the irrigation of the irrigation aspiration always faces the angle and not posteriorward, wherein it has a chance of actually hydrating the vitreous, resulting in a vitreous herniation. You go ahead and proceed with your cortical wash. However, it's very important to remember one important step. That is, when you need to change the sides of the irrigation aspiration to complete the second half of the cortical wash, it is very important to ensure, without fail, that you remember to perform a viscofluid exchange prior to changing the hands during the irrigation aspiration in such a case. Performing this step of viscofluid exchange will prevent the herniation of vitreous through this opening in the posterior capsule. Now, if you're able to successfully completely remove the cortex, at the end of the cortex wash, once more perform a viscofluid exchange prior to the implantation of the IOL. In this case, you will see how I'm able to successfully implant a monofocal IOL of a plate haptic design within the capsular bag itself. Now let's see what happens in this following case. I notice that there is an opening in the posterior capsule, and having noticed that, I perform a viscofluid exchange before getting my source of irrigation out of the eye. But look what happens as soon as I get the probe out of the eye. As soon as I do that, I notice a vitreous herniation into the anterior chamber as well as out of the eye. Now that there is a vitreous prolapse, I proceed to performing a limited anterior vitrectomy using a 20-gauge cutter. I start with cutting the vitreous in the wound, followed by the vitrectomy of the disturbed vitreous in the anterior chamber, and finally in the area of the rent itself. Once the vitreous is cleared, I then go in the IE cut mode of the vitrector and then proceed to removing the cortex with the vitrector itself. Now we do know that when we have a harder cataract, there's an increased propensity of creating a PC blowout while performing an aggressive hydrodissection. Now this is a patient with a relatively dense nucleus sclerosis and a posterior polar cataract. Whilst attempting hydrodelineation, there is an accidental hydrodissection in this case, resulting in a posterior capsular blowout which appears like a pupillary snap. Now once there is a pupillary snap, there's obviously a posterior capsular blowout, for which I now manipulate the nucleus out into the anterior chamber and then perform a nucleus emulsification in the anterior chamber itself after coating the endothelium with a dispersive viscoelastic. I think it's important to remember that if you choose to emulsify the nucleus in the anterior chamber, there's a significant possibility of damaging the corneal endothelium. So should you choose to do so, it's important to intermittently keep injecting a dispersive viscoelastic to protect the corneal endothelium. Another possibility that we could consider here is performing an IOL scaffold, that is, placing the proposed IOL in the anterior chamber over the iris prior to emulsifying the nucleus, with a view of helping prevent a drop of the nucleus into the posterior segment. The next case is a patient with a grade 2 to 3 nucleus sclerosis with a posterior polar cataract. While performing the primary chop, as a result of an excessive lateral separation itself, there is an opening in the posterior capsule. As soon as the surgeon tries to go in and break down the nucleus further prior to its emulsification, there is a tilting of the nucleus with a nucleus drop. Having noticed this occurrence, I then introduce a 26 number needle via the pars plana to prevent the fragments from falling down. The fragments are then brought up into the anterior chamber, after which they are removed from the eye turn by turn via a scleral tunnel which is then created, prior to performing a limited anterior vitrectomy. The next case shows a similar occurrence, a grade 3 nucleus sclerotic cataract with the posterior polar element. I now proceed with performing a direct chop with a limited lateral separation, but whilst doing so, watch what happens. Midway during the nucleus emulsification, and most likely as a result of the intraocular manipulations itself, there is an opening in the posterior capsule which results in the dropping of one of the fragments into the posterior segment. At this point, it is extremely important not to chase the fragments on its way down, because that could cause significant damage to the posterior segment. I let the fragment fall, perform a viscofluid exchange, and then bring my instruments out of the eye. Having noticed a vitreous disturbance, I then proceed to performing a limited anterior vitrectomy, after which I place an IOL in the sulcus, close down the incision, and hand the patient over to a vitreoretinal surgeon to perform the removal of the drop fragment. It's important that we secure the wounds prior to handing the case over to the VR surgeon. Another step that should be avoided in a patient with a posterior polar cataract is performing the capsule polishing. The mere act of polishing the capsule can actually endanger an already fragile posterior capsule and result in a posterior capsular opening. This is what you will see that happens in this next case. Now, once there is a limited opening in the posterior capsule, even though it is not a typical opening of a posterior polar cataract, here's how I think is the best way in which we should proceed. With the help of the intraocular forceps, note how the surgeon converts this small, limited, ragged opening in the posterior capsule into a stable circular capsular excess. Now, once you've achieved a stable round opening in the posterior capsule, there is no longer a fear of it extending. The surgeon now proceeds to implant a 3-piece IOL within the capsular bag. Moving to the last case in this series, It truly isn't over till it's over. Do remember that even performing a stromal hydration can result in the opening up of the posterior capsule in a posterior polar cataract should it be done with excessive force. So moving to this case, this is exactly what happened. The surgeon, while performing hydrodissection, has accidentally created an opening in the posterior capsule, which was missed at the time of the surgery. Day 1 post-operatively, during the rounds, the surgeon noticed that there is a classic opening in the posterior capsule. This possibly happened as a result of an aggressive stromal hydration. This brings us to the end of the video tutorial. It has been my endeavor to discuss different surgical scenarios of an opening in the posterior capsule occurring at different stages during the surgery and the principles of management of these cases thereof, should an opening in the posterior capsule occur. I hope you found this video tutorial useful. Thank you.